being said, I know there are some guidelines or some physician papers out there that say, oh, if you're 60 and you have a hypoglycemic count, then you have to go, once you hit 60, you have to go on myelosuppressive therapy to lower your platelets. And the patients always joke with me, well, I was 59 and I didn't need chemotherapy, now I'm 60 and I need chemotherapy. And I don't think either of us practice that way, or even 70 or 80. You know, I've had some 85-year-olds who've had ET for forever, and their platelets are over 1 million, and they're coming to my clinic because their last hematologist fired them because they said, you know, either you take hydroxyurea or you have to leave my clinic. And they're like, fine, I'll go to Hopkins and Stein and Molitor and we'll tolerate this. But I understand they're right. You know, if they haven't had an event and they're feeling well, we will just proceed. So that's how age, you know, their age is purported, it is a known risk factor, and no one wants anything bad to happen to our patients. So that's why age plays such a key assessment tool.
If I could also, very brief, age doesn't necessarily define you. There are patients who are 40 who have 65-year-old blood vessels, and patients who are 65 who may have a vasculature of a 40-year-old. So this is what we don't necessarily like about the guidance we get worldwide about what we're supposed to do with our prescriptions. Age reproducibly increases vascular risk, but we'd like it to be a little more personalized, individualized when we're prescribing therapy. I have a handful of patients who I've met in a 58, 59, they've had their 60th birthday and come in, and they're no different than they were when they were 58. So this is the part where we're looking at more personalized approaches to preventing thrombosis. Age does impact treatment, and I think it must be said that if we're thinking about myelofibrosis and if we're thinking about stem cell transplant, this is where age can play a major role. Perhaps this is a risk worth taking in a younger patient. Perhaps it's too risky in an older patient. So we don't like to base our decisions entirely on age, but there are some circumstances where we must. And I think the same comes from hydroxyurea. If you're a younger patient who must be on such a therapy, perhaps if we're looking at logically or very realistically, hydroxyurea could be a medication on for 25 years, there might be consequences to being on it for that long. So age, we don't like it's not the only thing we use to make treatment decisions, and we really want to look at the whole person, the individual as you bring up.